Welcome to the Kidney Week 2020 Reimagined podcasts, where ASN President Anupam Agarwal will be hosting discussions about various topics in nephrology. ASN thanks Akebia Therapeutics for support of this podcast.
I'm Anupam Agarwal, President of the American Society of Nephrology. With us today for this podcast, we have Dr. Kathleen Liu, who's a nephrologist from the University of California, San Francisco, and Dr. Kenar Jhaveri, who's from New York. You both have been really active in this COVID-19 pandemic with patients with acute kidney injury, needing dialysis, CRRT, and so on. So maybe if you all can give us a brief overview of your experience during this pandemic and how this experience may have evolved over the past few months. You think things have gotten better where you are, or have they gotten worse in your opinion? So maybe we can start with Kenar.
Oh, thanks, Anupam, and Kathleen, nice to meet you. As you all know, New York was hit pretty hard in March, and I still have those almost like PTSD nightmares of my weekend call in mid of March, where all of a sudden all those consults that were fun, interesting onconephrology electrolytes were changed into COVID. It basically became, within 2 weeks, the entire hospital where I work, which is around 900 beds, was an entire COVID hospital. So you can just imagine the consults going from a census of 20 to almost 100. So we had to deploy more nephrologists in the hospital, redeploy some of our fellows so that everyone was in the hospital. I would say we were getting a consult an hour almost, and we had almost like a 37 to 40% increase in renal consultation over a month or two. And then that led to the increased need of CRRT. Almost every patient that we were consulted on either required dialysis or continuous form of therapy. Even the need orders of CRT went up like significantly, almost like 500-fold in our health system. So those were just like that. We would just walk in and it would just be consults after consults. And it continued, I would say, for most of March, April, and early May. And we really had to make sure we had enough supplies, enough personnel, enough nurses to provide for dialysis. And I think ASN's committee on COVID was very, very helpful, got all the New York programs together and made sure that everyone was trying to get what we need in terms of supplies. Our health system was really on top of it as well, and it gave us enough sort of monetary help to get whatever we needed in terms of CRRT and personnel. And then I would say mid-May, June kind of started trickling down almost back to the old census, but almost like a lull, because I guess people were scared to come to the hospital for even non-COVID stuff. And then July, August was back to almost non-COVID. And September, October, we're starting to see a little bit of trickling up of cases, but it's nowhere the amount of COVID cases we saw in March, April. And almost the percent of AKI we saw was almost 40% back then. I would say it's even like less than 5% right now. We're not getting called as much as we used to get called. But that's sort of a brief overview of what happened.
Kathleen, can you tell us your experience on the West Coast?
Yeah, I would say, so I'll say, I guess, sort of by way of background, right, in addition to being a nephrologist, I'm the medical director of our medical ICU, which has been one of our two predominant locations for our COVID patients. We obviously have been very fortunate on the West Coast. We did not have the extreme conditions that Kenar had in New York kind of during the first wave. We certainly had patients with COVID, with AKI, right, and very rapidly had to change protocols, for CRT, for example, to try to minimize in-room time for the nurses, deal with the issues that everybody's talked about with anticoagulation with these patients, quite different from for our usual patients. We had a fair number of patients with AKI. We have a large kidney transplant population and catchment, and not surprisingly, a lot of those people developed dialysis requiring AKI. I would say, we did have sort of that second surge in the summer with increased numbers, and very similar to what Kenar described, the incidence of AKI kind of in the second wave much lower, and for whatever reasons. And now, oddly, as the rest of the country is starting to enter wave 3, we have not seen that uptick yet for reasons that aren't clear to me, but we'll see what happens.
So in your opinion, what is important to keep in mind when you're treating a kidney patient who has COVID or a COVID patient who develops acute kidney injury? Kathleen, maybe you can go first.
Sure. I guess when I first heard you sort of ask that question, Anupam, I think the first thing that I thought of was sort of extreme flexibility, right? I think all of, sort of from a global perspective, right, this has been sort of a highly dynamic time where the whole hospital system across the country has been sort of stressed at once. And so, being a little bit mentally flexible about what supplies, what will be in short supply potentially that day, nursing staff, heparin, CRT solutions, cartridges, et cetera. So I think that's one thing. I would say that I think these patients have been a little bit different than our usual sepsis-associated AKI patients. I think we learned in the first wave that probably some of these patients came in relatively volume deplete after being at home for a number of days, afraid to come to the hospital with high fevers, perhaps diarrhea. So they came in more volume deplete than I think we think of our typical AKI patients. And then I think the other big thing that comes to mind for them is just the sort of hypercoagulable state that they have, that I think we still don't understand very well, frankly. And we were fortunate to never be so swamped during any of the surges that we've been able to tailor our anticoagulation strategies quite a bit. And I'll note that different patients seem to be at quite different places on that hypercoagulable spectrum. Some people tolerate CRT with not much anticoagulation. Other people really do need full dose anticoagulation to tolerate the circuit.
Kenar, do you have any thoughts on that topic?
Yeah, so a couple of things. So first, I think when we saw the AKI that was happening, and it was happening so fast, we were trying to still learn, what just happened in front of our eyes. It was so rapid. But we noticed that some of it was volume depletion. We saw a lot of rhabdomyolysis too, but there was a fair amount of volume overload too. A lot of these patients did have cardiac events and heart failure as a result of that, leading to more of a cardiorenal syndrome. And then we also were seeing a lot of these clotting, DVTs, thromboembolic events, and thrombotic microangiopathy. So it was not always a straightforward slam dunk, but majority was volume depletion and ATN, which we would see in most of the septic patients also. So while I agree with Kathleen, I also disagree that there might actually be very similar to sepsis. It's just that we were overwhelmed with the virus at one area or part of the country, that maybe we're seeing all manifestations at one time, and maybe that's what it was. In terms of anticoagulation, there were times where CRRT, we had patients both on heparin and ergatroban to really prevent the circuit from clotting. So I've never done that in my life, to have both anticoagulations on board, but we just had to, otherwise they would clot, even with the very high blood flow rates on CRRT. So it was just a very challenging time in terms of making sure the anticoagulation was perfect. And in terms of the CKD patients and dialysis patients that came in with COVID, our renal patients, they were at a higher risk of mortality. We assumed, and then later showed, and most have shown that. And we just had to be very careful, like contact tracing them and making sure the units where they interacted with the other patients were not, getting infected. And I think a lot of us nephrologists lost dear and patients that were very dear to us for years, dialysis patients during this pandemic.
Kenar, did you see a lot of transplant patients at all, or Kathleen?
Yeah, we actually had a fair amount admitted to the hospital with transplant-related AKI, but some of them were just more pneumonia admissions. But it was not as many as dialysis patients or AKI non-transplant.
So Kenar, I was just going to say, I think we actually largely agree. I think my only point was that as opposed to your usual sepsis ATN patient, these people had more volume depletion up front than some of them had more volume depletion up front. I mean, I usually think of my septic patients as not being that volume deplete when they come to the ICU.
True. Yeah.
And I think our experience in Anupam locally for our quaternary care hospital has been that we did see transplant patients in part because they got referred back to us for quaternary care. So we have had a fair number. We've had a fair number of patients with kidney transplants in our ICU with COVID ARDS, but that's probably because we have a huge denominator with a very large transplant program.
Sure.
And we were fortunate, I think, in that because we weren't overwhelmed. One of our local units, for example, in San Francisco, that was a brand new unit, was able to rapidly convert to a COVID shift, and so patients from all for-profit dialysis chains in the city were able to cohort on shifts fairly quickly.
I mean, one thing, Anupam and Kathleen, we noticed is our PD patients, there were not that many admitted, which was actually tells you the beauty of PD and home dialysis and keeping them safe away from all this. And of all the 400-some patients admitted to our hospital on dialysis, only 11 were PD patients. So a very small number of came into the hospital, even though they were infected. They might have been, stable at home, or they just didn't get infected.
For the patients who were, fortunate to get discharged with COVID and AKI, have you all seen any with CKD or prolonged delayed recovery from AKI in the clinic setting?
So yes, I have. A few of us have. If they did recover, they did fairly well, actually, even if they were on dialysis. Few of my patients actually have a creatinine of a 0.8, 0.9 after a few weeks on HD or if they were in the hospital on dialysis. So if they actually recovered, they did fairly well, and not a great amount of them stayed on dialysis. So I think we should really do our best to save these patients. I think that's the take-home message,
Kathleen, did you see any patients as follow-up?
So right, by true disclosure, I'm a nephro-intensivist, but I'm not so I do not have my own personal outpatient clinic. I think to Kenar's point, our patients who've had AKID have done very well, and I don't think we actually have discharged anybody from the hospital still on dialysis. We actually have one of our AKID survivors speaking on Saturday about his experience, mostly about his COVID experience, but also about sort of coming off dialysis. And even our patients with transplants, who had CKD before, have been able to come off and make renal recovery to come off dialysis.
What do you think is our biggest blind spot or a gap in knowledge when we are trying to understand how COVID affects the kidneys? Clearly, we've learned a lot, but there are still major gaps in knowledge. What do you perceive some of those to be?
I mean, I think it sort of speaks to what Kenar spoke to, right? That COVID-associated AKI is many different conditions, right? Some patients have rhabdo, some patients have sort of a sepsis ATN. There's clearly this collapsing glomerulopathy that's been associated, maybe TMA, right? And so I think, understanding sort of what's going on with a specific patient and how to tailor, sort of how we can best tailor treatment for individual patients, sort of beyond the dialysis piece, let's say, is sort of a large unknown.
Yeah, so I think the two gaps that come to mind is one, again, like why do some patients just get a regular ATN and some get a thrombotic microangiopathy and some get this collapsing or other forms of GN? We actually saw ANCA vasculitis with it. We saw membranous. So why are some getting these GNs and some getting the TMA? And also, is the viral load really important? I think it is. I think the viral load in March and April in New York was so high that maybe that's why the AKI is much more prominent as opposed to now. Maybe that could be the reasons why we're seeing such different variations, or it's the treatment that's having an effect. We're giving a lot of patients steroids and remdesivir now, which we were not earlier on in the course of March and April. So I think those are some places where we still need a lot to learn. I think there is a nice abstract at ASN from the Bronx, from the Brooklyn folks, showing that the AKI got significantly better earlier on when they gave steroids in patients who did not get steroids. So I think that'll be important to see if the early aggressive treatment with steroids and remdesivir, if that affects renal outcomes.
Tell us a little bit about what do you think our research priorities should be in terms of COVID-19 related research. Kathleen, you want to take that first?
Oh, I'm thinking about that, Anupam. I mean, I do think one area that I think is that I think we've both highlighted, but I think to Kenar's point, right, these patients actually have a very good chance of making renal recovery if they are able to survive, right? So I think, yes, there's a lot of research we could do about pathogenesis, pathophysiology, but I think from a patient-centered perspective, sort of understanding what we can do to optimize recovery is really important, right? And I think prognostication in these patients has been a real challenge, right? I mean, our experience has been we've had some people who have, had very prolonged courses in the ICU, but are able to survive and then recover remarkably well for people who were critically ill for 6-8 weeks. So again, understanding sort of how to prognosticate when you're not in massive, overwhelmed pandemic, I think is something that is still somewhat challenging for these patients.
Sure. Kenar, what would you think would suggest as research priorities that would be COVID-19 related for the kidney at least?
So this is where I put my onconephrology hat on, and because, again, like most trials, these patients are getting excluded. CKD, dialysis patients. I think it's about time all these patients get included in remdesivir trials or other large trials happening with COVID. Because otherwise, our patients are always going to get neglected. I think that's one of the biggest research priorities that we should have. And other than that, I think focusing on learning the cause of AKI and the pathophysiology might be important. And I don't know if this is something that we should proceed, but I've read and learned a lot about machine learning recently, and I think predicting the need for CRRT in the ICU in any septic patient, it could be COVID maybe or any AKI, will be, I think, important because what we learned in this pandemic is supply issues that come up, and if we can predict the percent that will require CRT, we can predict then how much stuff we will need to treat these patients.
Well, thank you, Kathleen and Kenar. Really appreciate both of you taking time of this busy Kidney Week Reimagined to spend with this podcast, and really appreciate everything you've been doing on the front lines, taking care of patients and with this COVID-19 pandemic. So thank you both very much.
Thank you, Anupam.
Yeah, thank you, Anupam, for having us.
ASN thanks Akebia Therapeutics for support of this podcast. The content of this podcast is for informational purposes only and does not constitute medical advice in any way. Thank you for listening to the Kidney Week 2020 Reimagined podcasts.